how cool I am.
All right, Asagi, thanks. Welcome. I'm going to talk very quickly, which won't be hard because I grew up in New Jersey. But we'll do a very quick 10-minute overview of T1D Exchange, some of the other stuff that goes on aside from the Quality Improvement Collaborative. So certainly you've heard a lot from Asagi about that. And I should say, by the way, I'm Dave Walton, the CEO of T1D Exchange. I also am an agent for Asagi, book speaking gigs for him. And I think he's talking to a regional University of Miami event tomorrow. And now that I heard about the assistant professor thing from Francesco, just we'll keep an eye on that. Okay. But a few of the areas that we focus on outside of QI, we have a self-reported patient registry that is growing about 75 to 100 people every week. Our marketing team works hard to try and find people with type 1 through referral partners, through Facebook, advertising, any place where we can find people with type 1. And we have them join this registry. I'll tell you a little bit about that. Asagi mentioned some of the custom research or the real world frontline kind of provider work that gets done, special projects. We also do other kind of research that's it's with patients directly. And we do that through some of it's our own ideas that we work for. There are other people come to us with ideas, or the industry may want us to help take a look at a particular topic. Our online community, some of you remember the name Blue from a number of years ago. It's got almost 30,000 email addresses in there, people who get a question of the day and news articles from us, and really more of a they want to hear about the what's going on in the T1D world. So that's something that we also use to recruit for studies that people might want to do, which is kind of the last area here, which we help recruit for other people's studies, whether that be an in-person clinical study of a novel biologic or cell therapy, or it could be a simple survey on telemedicine. Like Dr. Frost and UC Davis, we did that a couple of years ago, and we're able to get a lot of good results for that. So we want people with T1D to be involved as quickly as possible and as meaningful of a way as possible as any of the work that's being done out there. So we've gotten pretty productive in the last few years. We are obviously the growth of the collaborative, extremely large, and some of the other work that we're doing is part of the way that we're able to keep growing, and again, growing our registry and the amount of research that we're doing. The size of the organization is getting larger. So we've got 34 people now, actually 35, because Ginger Vieira just joined us, if you know her from social media, 2 weeks ago. So she's documenting some of the things from this event, and you'll probably see that on LinkedIn and other places. But we have a talented team, and PhDs and MPHs and MD MPHs, but everyone, regardless of their discipline, does care about the mission and trying to improve outcomes for everyone with T1D. And we do that through real world evidence, and we do that through collaboration. And there's no better example of that than what's going on here in this room. And we're very proud of it. It's like our flagship program and initiative, and really enjoy when I'm doing overview presentations to whoever it is, spending a lot of time on QI. Asagi does a much better job than I do, so I don't, and given the nature of it, I don't need to go into that right now. But what I will do for a few minutes is just quickly highlight the registry, the custom research we do, and the recruitment, and just to give you a flavor of what that is. So it's all virtual. Again, we're finding people through whatever means that we can to join and answer a 33 question baseline questionnaire. We also ask an annual questionnaire. But then once we have that kind of background information on people, we can then probe a lot of different areas and go deep within a particular one and send out a custom survey on a particular topic. Connect. Hello? There we go. And so we can go deep. We have some things we've been doing with device data. We've more recently started asking some questions on diabetes distress based off some research that we conducted internally. So some good information, but really it's more of a setup for the follow-on. And one of these projects, we had someone who has a lot of expertise in the area of diabetes distress do some work that determined if we do 2 questions, it correlates pretty well, with the broader questionnaire. So we're now making that a part of our core and annual questionnaire. We have good coverage across the U.S. We gather comorbidity information, and so we talk to partners about the number of people we have in certain conditions where there could be an interesting collaboration. And as you can see, as people get older, you would expect there to be more comorbid conditions that we could take a look at. On the autoimmune side, we talked to the celiac, Beyond Celiac, and other organizations that have an interest in autoimmune diseases, and we think there are some research opportunities for us there to get involved in. This topic about age and age of diagnosis, it's come up a lot. I was diagnosed 27 years ago at 24, and that wasn't a common thing. Thankfully, the people at UPenn didn't give me metformin and tell me to go on their way. So I was able to, right away, get diagnosed appropriately and then move forward. But we have a representative cohort from an age standpoint, and I think this almost 50% being diagnosed as adults seems to corroborate what we've seen in studies that have been done on the topic. So a range of qualitative, quantitative research we can conduct. Again, analyzing CGM data, that's an area that we've been focused on more. We've got 1,200 people who've linked CGM data to their registry, and we have another 2,000 that we expect to have done by February timeframe. So that gives us a lot of opportunity, to look at various things in detail. And diabetes distress was one that we did in the past year. But we've done a lot of work with glucagon, hypoglycemia. We were getting involved more in screening with a project we're doing, looking at people's awareness, attitudes, perceptions about screening for autoantibodies. And we've also started to broach the topic of different kinds of data, photos being uploaded to us of sensor sites. We've contemplated some virtual study ideas that people have approached us about. So we expect in next year that you'll see a broadening of that. I won't go through the results just given time, but just to give you a flavor of the combination of device data and survey data, we can dive deep into a number of areas. And I referenced the diabetes distress, on which we're working on a publication on that work and the benefits of that two-question screener. We looked at impaired hypo-awareness and how often severe hypo events are occurring for people. And these are people that, that primarily we recruited from our registry who are very tech savvy and are, kind of more aligned to research. And we saw a lot of severe hypo events being self-reported, which was interesting information that we gathered. But then taking a look at their actual CGM data and seeing, well, how often this is happening in a year or in a week? How often are they spending 2 hours consecutively below 54? And it's more than I think we might have estimated prior to doing this work. So some interesting things that are just the beginning of this is one of the first projects where we had a large number of people, over 1,000 people sharing their CGM data. I also mentioned the study recruitment. It's an area that's been growing. And again, that can range from in-house or in-person clinical studies to things that are just virtual. And one thing we just tell all of you is if you're if you need assistance in getting patients, we've got patients in all the zip codes who are willing to come in. They want to hear about research, and we're convinced that we can speed up any study of any nature. It just needs a little receptivity of people to accept patients from other areas, not the ones that they're seeing routinely. So that's something that we're definitely making a big push on, because we want to see research happen faster, and we can play a part, and we want to do that. I mentioned the online community and the resources that we do have on our website as well. So that's patients can get, or people with diabetes can get a good overview of different technology. We do questions a day on all kinds of topics, everything from automated insulin delivery to psychosocial issues and so forth. So again, we get a lot of quick pulse checks from doing this, and we have almost 10 years of back data on this that we have at our disposal. So we often look at how things have changed over the years. So a number of areas that we've kind of expanded in 22, and Osagi mentioned some of them in terms of QI. And I went over a few of these on our custom research and our registry work. One quick comment on type 2. It's been something, when I joined 3 years ago full time, it was actually right around the Houston learning session. So number one, I learned just get out of the way and let QI do his thing, help him with any barriers if so, but that there is so much potential in the collaborative. I'm glad to see the way that's really blossomed over the last 3 years. But type 2 is one that came at us from every angle, from adult endocrinologists in particular, but some pediatric too, from industry, from payers. The results out there in the real world for type 2 are, even more discouraging than some in type 1. And, we think we can lend a hand with that. And in terms of a name change, we did register T1D Exchange.org like 3 years ago, thinking that could be a possibility. Believe me, we've type 1 is that's our focus, that's where our hearts are. But there's a lot of work to be done in the type 2 arena, as you all know. So we're certainly looking at intentional, smart ways to get involved within that. And we did just sign a grant with the JDRF that has like 5 different areas. One of them is around screening, and we'll be taking a look at if our registry platform can be used to keep track of some real world results of people being screened. Can we use all these people in the registry to contact immediate family members to try to get them to screen? Can we augment what JDRF's doing with their own program? So that's one area that we're looking at. And I think testing real world operations is something that a lot of people are interested in. And that's something that we'll take a look at probably with 2 centers in a pilot in the next 18 months or so. So we're still working. This is fresh. This was literally consummated a couple of weeks ago. So that's something that some of you may hear about. And then lastly, I'm going to be 4 minutes late. Just want to thank the Helmsley Charitable Trust. Very thankful for their continued support and their particular interest in QI. And we also have other organizations, many of which, again, Osagi just mentioned previously. We're very excited about what's happened. We're very excited about the future. And I always thank people who decided to work in endocrinology and diabetes care. We wish there were more of you, but we're thankful that you made the choice to do that, and that you're putting your hearts in to help people with diabetes improve their care. So thank you.
Right. So we'll have time for 1 or 2 questions for Dave and I, and then we'll have a break for 10 minutes right after that. Any questions Dave or myself can take?
You just want to show that you're taller than I am.
So Principal, you do for wonderful presentation. I will speak loudly. I like picture of him in New York. So hopefully question that I was really struck by, Osagi, is we talked about our data and data collection and how important it is. it's not Sunny, but two big question marks that I'm not Sunny, and I know why. My question to you is, in addition to our site just providing the data, we discovered about Sonic is that there were some challenges with how it was being collected. For example, we got back a report that said 10% of your patients don't come. We've done studies that have actually, we know we've had separate data collections that show a lot more. Any guidance the T1D Exchange want because it helps the people internally that are collecting this data would be incredibly helpful. How do you search your email? What do you do? I think that would be something that really might help leverage us to ensure that they're really more active data. And you know, I don't know if we're the only site that has this scenario, but I feel like we're missing some people who for something else or how the search is being done. Thank you for that. And then my other comment is when I heard the comment about social worker on the adult side, and then also commenting about that too, is this is something that you can help us leverage from an institutional perspective. I tried to really get social work support within our adult side, UVMP, on adults. Ways that we can learn to do this to get our institution interested would be huge.
Yeah, I can take that first question, and Dave can sort of talk a little bit about like advocacy generally. So in the question about like data and like collecting that piece, yes, you know, Sinai is not the only center. We see a lot of that. You know, two quick things there. One is the data science committee with Joyce and Marina. That's a big area of focus. So I think there's a lot more happening there. A lot of templates, a lot of ideas being shared, all of those sort of things. You know, Ryan is not his head. Ryan is also doing a huge work too with center centers. We have a lot of Epic users too in the network, in the collaborative. So we'll do a better job in sharing all that resource to promote that. And tomorrow, Mark is doing a session that I believe we'll probably be in this room tomorrow afternoon, a session on data and data integration and some conversations. So I think that Mark will have some other ideas to share too on like that whole aspect there. So there'll be a lot that'll be covered today and tomorrow on that piece. We do, you know, we're involved in advocacy efforts, like a partnership with other organizations. And Dave, you want to speak a little on that?
Yeah, I had an advocacy slide in there that I took out for time, but I mean, I would say that part of the beauty of the collaborative is when we pull data on a particular topic like CGM and then show how people with CGM do better in COVID and do better in general, that helps with some of the discussions that some have had with state Medicaid. If there are examples of how social workers are being used at other organizations within the collaborative, maybe after depression screening, then, okay, what do we do then? And I mean, I remember being struck in Houston 3 years ago about the way that they were trying to intercept people who were at their visit and screen and try to get someone to meet before they left, give them a free lunch or some tactics that you had. But some of those examples that you can pull where there's actual some evidence so you can present it to your team and your finance person, most likely, about why there's a benefit to doing it. So I don't have an exact answer, but I know that's some of the power of the collaborative and leveraging what others have done to kind of help your cause.
Okay. All right, thank you, Dave. So